in the COVID discussions, the American Association of Medicine in the Person. My name is Mark Bazik. I'm a surgical oncologist at the Jewish General Hospital in Montreal, Canada, and I'll be moderating tonight's session. I just wanted to give you a bit of an introduction for those who don't know about the American Association of Medicine in the Person. It's an organization formed by some friends about 10 years ago, 11 years ago now, whose aim is essentially to shine a light on the humanity in bringing together physicians, nurses, physiotherapists, social workers, and other health allied professionals, so that we can help each other in regaining or preserving or going deeper into the humanity of our professions in the care of the sick person. So we usually organize a Med conference every year, and this year, because of the COVID situation, that has been postponed. And because of the questions that have emerged due to the COVID situation, the particular COVID situation, questions which are very deep and relate to why we went into the profession, as some people have said, or how we can be professionals right now. We thought we'd launch this series and invite you all to the Zoom conference every few weeks with a new speaker to share an experience of what he or she has at the time. The last speaker we had was Dr. Amadeo Capetti, who shared his experience as a microbiologist in Italy, which was the first hotspot, if you will, of the COVID crisis, of the pandemic. And tonight we have the pleasure of having somebody from the second, if you will, hotspot of the pandemic, New York City. And so it's my pleasure to introduce Dr. Francesco Rotatori. He is an interventional cardiologist and the chair of cardiology at the Richmond University Medical Center, serving New York City, Staten Island, and Brooklyn communities. He earned a degree in medicine from University degli Studi in Milan, Italy. He completed his internal medicine residency at Richmond University Medical Center, and then a fellowship in cardiology and interventional cardiology at SUNY Downstate. He's board certified in internal medicine, cardiovascular disease, interventional cardiology, nuclear cardiology, and echocardiography. It's quite a bit of board certifications. He is a cardiologist, as you hear, and was involved in the thick of things, as he will tell you now. And he's also married to Susie, and they together have 4 children, Matteo, Tommaso, Emma, and Miriam, and he lives in New York City. So welcome, Dr. Rotatori. The format tonight will be somewhat similar, though slightly different, thanks to your comments after the last session. It will be a question and answer period, and I'll be asking the questions to Dr. Rotatori. However, this time, hopefully we'll have more time for the questions. And what I encourage you all, those who have questions, is to write them in the chat. You see the chat button, which is sort of in the middle of the bottom of your screen. You write your questions as they come up, and they'll be sent to me as we conduct this interview. And some of those questions I'll select and pose them to Dr. Rotatori. And I don't know how many we'll be able to ask of your questions. We'll see how much time there is. This whole thing will last about an hour. So I'll begin with a few questions that I have for Dr. Rotatori. Welcome, Francesco. Tell us your story in a sense. So what were you doing before the pandemic, and then what happened?
Yes, good evening, everybody. I hope my voice comes clear. It's good from the host. It's good. It's good. All right, great. So yeah, I live in New York. I live in Brooklyn, but I work in Staten Island. I've been working there now for. I started my residency in 2007. So I work as a cardiologist. I have an outpatient, pretty strong practice outpatient, and inpatient, I'm an interventional cardiologist. So I run a cath lab where we do a number of procedures every day, and that has been my life for the past few years. When the pandemic hit New York, our hospital was pretty much at the same time as the other hospital in New York, got flooded with patients, and that was something that happened in a matter of 2-3 days. We went from 0 to 100, really. I mean, like, giving you some numbers to understand, my hospital is a hospital that has 160 beds, which generally about 120 are full, sometimes more, sometimes less, but something like this. And in a matter of a week, 10 days, we ended up having about 380 patients, inpatient. So we tripled the amount of patients that we have in the hospital. And in particular, we have, of course, had a lot of very sick patients. So we do have an intensive care units of 10 beds, medical intensive care units. We also have a surgical intensive care units, which is sometimes used as a board of patients from medical ICU. So we can get to a total of 20 beds but they're never, I mean, always never all medical patients. And at the peak of the pandemic, we had over 60 patients that were intubated, and another pretty much same amount that were on BiPAP or CPAP, so that they required an advanced level of care that would have required the intensive care unit if we had one, because at this point we probably had around 100 patients that required intensive care units. So we do have one intensivist in the hospital full-time, and we have another one part-time. So you can imagine that basically pretty much the whole entire faculty of the hospital has been involved in taking care of patients. And the ones that were more comfortable in dealing with the sickest patient, we really worked as an intensive care physician, or at least, I mean, for the part of the job that we could do. And so mostly me and my colleague in cardiology, we took most of the job in terms of intensive care unit, dealing with patients. So this happened in a matter of, literally a matter of 2 weeks. And I mean, I can go through the details and everything, but just to give you the first overall idea, you have to imagine that the first main problem that we have, you can imagine, I mean, you have a hospital that is staffed for 120, 130 patients a day, and now has 3 times the same amount of patients. On top of that, you have to add that in the first week or so, we had about 25 to 25% at least of our staff that went out sick because they got exposed to a patient. Initially, you know, the CDC, the Center for Disease Control, was giving different ideas. If you get exposed, then you're high risk, you stay home. And some elderly, I mean, some people in the staff that were like close to retirement, they just gave out the letter of resignation. So they're old and they won't take a risk. So imagine that on top of tripling your number of patients, you're also taking away 25% of your medical staff, nurses, medical assistant, phlebotomist, and all that. So it was a complete shock for us, complete shock. And we had to rearrange. We had to, and this was the first part, the first incredible thing that happened in my hospital, which happened probably in every other hospital, but I mean, I speak about my experience. There was a morning meeting that started every morning at 7 o'clock with the people most involved in this pandemic, and it was a true brainstorming in terms of dealing with every single detail. So I was getting to this meeting at 7 o'clock, basically flooded with ideas and things that I've seen overnight. Is like, this didn't work, this can't work, we need to do this, we need to do that. And what was amazing is that you have the administration that you have been dealing with them in the past, and it was a continuous, like, you know, a little bit of fight or whatever, and they don't understand me, they were just listening and trying to figure out how to make it happen what I was asking, sort of like in terms of how to better care for these patients, from a logistics standpoint, from a management standpoint, and then all the way down to how to treat this patient, which was probably one of the main tasks. And yeah, I don't know. Do you want to go with some specific questions, maybe?
Sure. I mean, one of the what kind of area does your hospital serve, or what kind of a hospital is it? Is it a general hospital? I gather. What is the indigenous population that you usually serve? Give us a bit of the context as well.
Yeah. So of course, Staten Island is an island. As one of the borough of New York, has half a million people, 500,000 people, and has 2 hospitals. And we are the second hospital, and the first. I mean, it's the amount of. I mean, the coverage of the island is kind of like 60-40. They cover 60%. We cover the remaining 40%. We cover the northern part of the island, which is also close to the ferry that goes to downtown Manhattan. And if you look at the percentage of population, if you look at percentage, we have a 30%. We have 30% Medicare. We have a 30% Medicaid. We have 30% other private insurance, and with a 10% of mixed. But so 30% of Medicaid is a pretty strong population. I mean, it's a fairly poor area right around the hospital. Very poor area of people with very little income and quite low social condition. The hospital is a standalone hospital. It's a community hospital. We have all the services except for CT surgery. We used to be affiliated with Mount Sinai. Cardiology is still affiliated, but we're not. We're a standalone hospital. So you have to imagine that even in terms of finances, we just had to deal with what we have. So it was not an easy task.
Okay, so tell us more than how things developed. How did it go then as these patients came in a matter of days?
Yeah. So just to give you an idea of what really happened, you have to imagine that you have. So let's say, first of all, what we did is that we moved towards a single bed rooms in all the hospital recently, and we basically doubled up again. So the room, they became a two patient room, and then we started to, of course, we started to admit patients that they will require intensive care units, but they end up going to a regular general floor. This was the first major problem. You have people that they require continuous attention, continuous care, and they can't get it because we just don't have enough people to do it. And then at the beginning, on top of that, there was also, the concern about the lack of knowledge about this virus, the lack of knowledge about, even for us, what kind of protection we have to use. I mean, is this enough? The beginning was really a shock. I mean, you imagine that. So a day before the whole pandemic, a week before the whole pandemic started, of course, Cristiano might know. I mean, we have friends in Italy, and I kept talking to them, and they kept telling me, this is a big problem. This is a disaster. You got to tell your people, administration, they have to get ready. This is going to be a shock and everything. You have to put a mask on, wear a mask, don't wear a surgical mask at least to go around and everything. And I get an appointment to one of the administrators with my surgical mask on, and then I come in and he's like, why are you wearing a mask? I'm like, are you sick? I'm like, no, I'm not sick. But as you know, this disease, there can be, healthy carriers and everything. I'm protecting others and everything. You say, well, no, I think you're scaring people and you should not wear a mask. And this is not my hospital. This has been said throughout the hospital. I've seen it everywhere. So the beginning for us was, okay, you shouldn't even wear a mask because you're scaring people. And then 3 days later, then we start seeing these images from China, how there are the COVID areas in which these people go in, they look like they're going to the moon, and they're all gowned up head to toe, and you're like, what are we doing? I mean, are they doing right? Are they crazy? What are we supposed to do? So then, I don't know, let's start, at least close the door of the rooms of the patients. Let's start wearing N95 masks. Let's start seeing, and then some people have better equipment, some people have worse equipment. So it was really a state of total confusion. Because, of course, we didn't know enough. Nobody knew. And even the information that were coming from the higher level were a little confusing. The CDC was changing guidelines every day. And one day you can wear a mask, one day you have to wear a mask, one day you have to wear a N95 mask, one day only for aerosoling procedure you have to wear a mask. So it was a total disaster. But at the same time, what really struck me was that the people working there, they started to get together. It was not something that we decided to, but there was a kind of there was a moment in which everybody, or at least a number of people, decided that we need to do something extra than just our daily routine work and everything. We need to step up and move to another level, which meant a lot of things, and which meant, first of all, okay, besides working hours, they went, we didn't even think of going home or when are we going home. I slept in the hospital and everything. That was not a concern. But the more concern was the one thing that I wanted to say tonight was I've been thinking a lot about this idea of what is the role of a doctor, right? What does the doctor do nowadays, right? So I read some interesting articles now. Kind of deviating, but I read some interesting articles lately about the fact that the doctor should still follow the guidelines or evidence-based medicine, and this is all true, of course. However, a doctor is also someone that is in the medical field, is taking care of patients, and looks at the reality and finds the needs of the patient in that specific moment, and then trying to deal with it, which would mean sometimes even, staying with the patient for 5 minutes, and then, being with the patient in the moment that is dying alone, of course, or even trying to fix problem from a logistic standpoint. I give you an example. As I said, one of the problems was that at the beginning, having all these patients sick in the rooms, isolated, some of these people, they will not even be able to communicate when they were having problems or something. And so this could be, in certain situations, could be even dramatic, And so I realized that one of the best way to deal with these patients would be to just have them in an open space in which I can just look at them. And so I said, I went downstairs, we closed all the outpatient. We had the endoscopy area where we do the colonoscopies. There's a big recovery area, which is a large space. And I went downstairs and I said, how many patients we can put in here? And then we counted, we can put at least, how many oxygen are there and everything. We can put 14 patients. So I went to the administration. I said, okay, we're going to do a new ICU in the endoscopy area. We're going to put 14 patients, all of them around. I'm going to watch them all. And I said, how are you going to staff that? I said, I don't need any. Give me 2 residents. It's going to be me, my colleague, 24/7. We'll cover everything. It's 2 of us, and give me a nurse. And then they give me a nurse. Then of course the nurse started freaking out, saying, how can I see 14 patients? I said, I don't think you can see 14 patients, but you can manage 14 patients if I gave you a bunch of extra arms, which means, so I went to my office where my my office was closed now because we don't see patients. I have medical assistant in the office. And I said, well, I started talking to them about what we were doing in the hospital. They saw all the excitement. They saw how I was crazy about everything that was happening. And I told them, who's coming help? Who wants to come and help? And they're like, okay, we'll do. So then I called the administration. I'm like, I found people to help. And then they accepted. And then, so basically my unit was run by me and my colleague, Dr. Galligan, who's another cardiologist, one nurse taken from the ER on a rotation basis, and medical assistant following, just watching patient by patient. I mean, they had like 3 patients each that they can just watch and then call me. I mean, the only thing they would do is like, this something is beeping, and and you go and check, or this guy is calling for help, but at least we will watch them. Then, of course, this problem, this unit got filled up immediately. Then, so we still had other patients upstairs. So I looked up online. I saw some hospital, they were buying baby monitors. So at least they could use baby monitors in the room and then use it outside and put them in the nursing station. So we went on Amazon, me and the chief of medicine, and we just bought them. We bought like a bunch of baby monitors. This was like, everything was happening in a matter of a day. I mean, and by the way, you go and buy them online and they are on back order, because now you realize that you're not the only one that had this idea, and everybody else is buying baby monitors, And it was like this over and over. Then imagine also this, then I get my 14 patients in my unit, and now I'm looking around and I see them, they're intubated, but then one of the residents who's very much into the ACGME regulation and everything, he tells me, oh, but if you can't do aerosoling procedure here because it's an open space, so you can't do BiPAP. I mean, you can do CPAP. You can intubate the patient, but you can't use CPAP. So I'm like, oh, okay. So now we're back in. So I can only take intubated patients. But then I come to the idea, is that what if I put a plastic wall in which I separate the patient from the nursing station, but it has to be a transparent plastic wall. So I call in environmental, the hospital, whatever, the facility, the builders, and I'm like, do you have a plastic wall that you can put in to cover all the patients? And they said, well, we don't have a plastic wall, but we have those plastic things that we use for work. It's not transparent, but it's clear. You could see through. Like, okay, just bring it on. So we clearly mounted all this to separate the patient from the nursing station. And then we mounted these ginormous HEPA filters that they would filter the air. And then the air was going to one room that had a filter that was pulling the air out because it was a negative pressure. So it was like an engineering work but it worked out. It worked out very well. At the end of the day, I'm IgG negative, so it went well. I didn't even get it. So that was something we did.
Did you have to do a triaging of the patients for ICU care, especially for ventilator usage? Question has been asked by one of the
yeah. So
persons.
For the ventilators, we did not have to. We were very lucky. About the 3rd day or 4th day that this started, we received a donation from FEMA, from the Center for Disaster, federal. They brought us 40 ventilators, 40 or 50 ventilators, plus the one that we had in the hospital, so we could use it, and we had no problem with ventilators. But let me tell you, because these are things that nobody thinks of, but you have to imagine that you have a hospital that has an oxygen system, right? But it's a hospital that is used to use, may have 20, 30, maybe 40 patients intubated at the same time. And now it has 150 patients requiring oxygen, or 200 patients requiring oxygen. One day I'm working and the resident calls me from SLB6 and saying, one of your patients on the last floor, on the top floor, it's desaturating. I go and see him and he's desaturating, but I can't figure out why he's desaturating. The oxygen is fine. And then I look at the oxygen. The oxygen actually is not fine. It's just not coming out. But the problem is that there was so much oxygen going on the lower levels that the pressure wouldn't reach the 6th floor. So now we have to struggle and take the patient off the 6th floor, sending patient to the 6th floor that should not be on oxygen, but we never had to make a decision in terms of we're not intubating. Although we had to make it, I mean, we were very reasonable with the families and everything. We had, I know some hospital, they send out what we call like a blank DNR code, you know. We didn't do that, but it is also true that we had to kind of realize when a patient was in the worst condition, and in which attempting intubation or ambuing the patient, doing chest compression would putting at high risk the whole staff. And we would do it. We did it multiple times, but only if we thought that we had a reasonable expectation of recovery, you know. So that was an important decision. If I have to say, one of the biggest problem in terms of having to decide, having to triage treatment, and it's something that hasn't been spoken a lot, but was dialysis. A tremendous amount of patients with COVID, they end up in dialysis, even temporarily. Just to give you an example, I was talking to one of the residents who was doing in the nephrology service. We have a nephrology service. Generally, nephrology service, there are like 10, 12 consults a day. He had a list of 75 patients that in their consult list, on which of them, 25, 30, they require dialysis. We have a three beds dialysis in the hospital. So I think decision in terms of who gets dialysis first and who has to wait, I mean, that had to be made, of course.
There was a lot of energy I could see, and a lot of at the beginning. What happened after a week or two? In other words, how were you able to? What happened? How were you able to maintain that, or what happened to the situation as time went on?
Yeah. Well, what really I think what really struck me is that even if at the beginning of this, it's your energy, I mean, you feel like you're gonna do this, you're gonna make it, and you're trying to do great things and everything, but also you see that you're failing most of the time. So despite all our effort, the mortality rate was tremendously high. So especially for the patient in intensive care unit, we have recently came out with our data, which are comparable to all the data that New York area has, and similar to the one in Italy. We had the patient intubated, there's a mortality between 85-90%. Wow. So and so, I mean, despite all our effort, we had to deal on a daily basis with failure, basically. So one was the failure. One was the absence of a consensus in the medical literature and in the medical community in terms of treatment. And on top of that, there is also I mean, there is this sense that I mean, not on top of that, but I mean, together with that, it comes also a sense of what am I doing? I mean, where is my realization? Where is my
fulfillment?
What do I get from this? I mean, so the point here is, I'm going to work every day, and I'm going to work as a doctor to try to cure people. I mean, to try to see them get better. And I always think that the satisfaction, the pleasure, the fulfillment in my job is to see the patient that walks out of the hospital and is feeling good, which is great. I mean, that video that came out on the ABC when we got this woman that we discharged, it was great. I mean, the whole hospital was happy, everybody was clapping, and it was great. But that happened once, and most of the other times we were just there seeing patient dying. And not only seeing patient dying, but also seeing patient dying probably in the worst condition possible, which means by themselves. The reality is that as soon as this pandemic started, there was a CDC notification, no one is allowed in the hospital, only patients. So nobody had visitors, everybody was on his own. And so, of course, they have their cell phone, they speak to the families, but then when they get sicker, they can't even speak with the families anymore. So now, basically, part of my job becomes stay with them in the closest when they die. So I say this because you're asking me, so what happened then? What happened then is that the life became really tough in that sense. It was a constant daily, constantly daily had to do with death and failure, if you want, in terms of the overall concept of being a healer or being, seeing people get better. So what that caused is, I mean, there's two aspects of this that of course helped me live those days. One is that you see constant, if you have your eyes open, you see miraculous things happening. And when I say miraculous, I'm saying something happens that goes, I'm not in a very spiritual way, I am not very good with that, but something happens that is, it goes against so now you have a kind of a mindset that says, okay, this is going to be another failure, and then something happens and the failure is not there, or at least there is something that is different from what you have already planned is going to happen. I'll give you an example. It's a very tragic example, but for me was really touching. I have a woman who was in her 50s, and she got intubated and she was going to die. The primary care physician has my cell phone and gets in touch with me and says the family is trying to speak to someone. And I said, okay, of course, tell them, give them my cell phone, and they can call me. So the family calls me, and the husband and tells me, she has a young daughter and a young son. They want to talk to their mom. Can you help with that? I said, well, she's intubated. She's not going to talk, but you guys can talk. And I'm thinking, okay, this is really depressing, what I'm doing now. So I get a phone call and I get this girl on the phone. And so I go there, passing the plastic bag, the plastic walls and everything. I go there. And I put the phone on speaker, and then I tell the girl, it's like, yes, I'm here with your mom. She's, in a pharmacological coma. She's on medication. But you talk to her, and this girl starts talking to her mom and says, I love you, everything else. And at that moment, the woman starts, the girl starts talking. Like few seconds later, after. I start seeing tears coming from the woman's eyes, which, listen, I checked 3 times to me, because I said maybe she was crying before, maybe she was hearing this girl, right? And we always think that, and the medical staff, now I'm not an intensivist, maybe there is someone here in the community that's intensive, can tell me how much these people understand while they're on propofol, Versed, and fentanyl, whatever they are on, and on a ventilator. But clearly that blew up my mind. It's like, okay, you see that sometimes being a doctor and being at the service of the patient, sometimes it's not just trying to cure them because, for instance, in this case, I'm not doing it. I mean, I'm doing something else. Or another time, and that's an example that I gave. I mean, I went to see a patient that was about to be intubated, and then it was 2 rooms upstairs. So this patient gets intubated, and the other patient is nuts. I mean, unfortunately, he's crazy, and he's screaming and yelling, but still on a BiPAP. I mean, so it's a disaster. You can't even understand what he's saying. And then he starts saying something about my cousin. And I said, dealing with this, then I turned and I said, let me just say, oh, who's your cousin, And then he says, oh, it's my cousin. And he says the name. And I'm like, oh, I know him. It's like, oh, he's a good friend of mine. And he's a good guy. And this guy changed completely. I mean, he was, moving. And as soon as he found a connection, so I spoke with him for 5 minutes about his cousin. Of course, I didn't know. But that created a connection. The guy calmed down, and then he was able to keeping his mask on and everything. So what are you? You're reborn with a creativity in this situation. With you're doing things you don't even realize you're doing things in such a in a moment or something like this. Or I had another patient that had Parkinson's disease and very bad and still on a mask and everything. He wanted to drink and water and I mean, I gotta go, I run, I have to go and see other patients and everything. And he says, I want water. I said, okay, I'll give you water. I mean, of course. So I take the mask off there. They can't be off mask for too long. And I bring in the cup to drink. And he's like, no, I want to drink by myself. I'm like, all right, sure. So of course he takes the cup to drink by himself, I mean, it takes forever. I mean, it was very slow and it was, and so I, took my hands trying to, help me through. And he's like, no, I have to do it by myself. I say, okay, maybe said, no, okay, let me just, so I waited literally, I waited 5 minutes before he started drinking. And then I kind of direct with my finger the cup so then he wouldn't just pour the water on himself and he was able to drink. Why are we doing what I'm doing? Why am I doing this? Because I feel I had the clear impression that my role there was not just being a doctor to cure people, which by the way I was failing tremendously on, but I was there to help them. I mean, when the best thing in your life is to find a reason for living. I mean, at least that's what I think. Although I've been a doctor for many years. Yes.
Just repeat that because it was garbled. Just repeat what we just said just now.
I said that the best thing that I think, in life is to find a purpose in your life, to find that you're doing something with a purpose. And interesting enough, you're a doctor and you do it, and you think that your purpose and that you're there. I mean, that I'm chief of cardiology there to make cardiology great in that hospital and do a lot of PCIs and do a lot of stents and stuff. And then I found myself that in that moment that I was more fulfilled, more aware of my role than anywhere any other time in my career.
Really.
And so that was definitely something really striking.
Is that what sustained you as the weeks went on and the fatigue set in and you saw more and more of those failures?
Yeah. So yeah, what sustains you is that. I mean, those moment of those particular unique moment. If you don't want to call it miracles, you don't need to, but you can call it some unique moment that they get to you. I mean, and also the other thing that really moved me was the unity with some few people that were with me. I mean, I call it my team, but of course, I mean, some colleagues there was an interesting moment. Of course, we're not a Catholic hospital. We're like multi-confessional hospital and everything. We have a pastoral service and at one moment one of the administrator got with this idea, because they were coming out with different ideas. We had I'll tell you other ideas. But anyway, so they came out with this idea, and at 12 noon on a Friday, and we did the speaker overhead that we generally use to call codes and codes and codes, people coding. One of the pastor or someone took the microphone and said, I just would like to have a few moments in which we can get together, everyone looking for his God or looking for whatever but just to get together and to realize that, to try to find the strength and to realize that every one of us that is here is looking for something, is looking to be a factor in this tragedy that is happening. So is trying to make a difference. I don't remember the exact word that he said, but what was interesting to me is that a hospital is a very hectic place. The whole hospital stopped for a second. I mean, it was like 20 seconds or something. And I was rounding with my residents that were from completely different. I mean, I'm super Italian, as you might have noticed from my very, very little accent. But so I'm Italian. I had an Iranian resident, a Chinese resident, a Pakistani fellow. We all stopped and we all looked at each other. It's like, we are all looking for the same thing, and the fact that so that's what he said at the really start. He said, we all admit that there is something that goes beyond what we see in terms of, beyond this situation of failure, situation of disaster, of uncertainty and everything. And that really moved me, because from that moment on, when I was working with the other guys, with my team and everything, we looked at each other in a different way. So what I'm trying to say is that I was not going to be able to sustain that by myself, but the fact that there were other people with me that were looking for the same thing, and maybe coming from completely even more because they were coming for a completely different background than mine, it helped me a lot. Yeah.
Mm-hmm. And how did it go with your family? What was the impact on your family? These 24/7 shifts and etc.
Well, of course, it's been difficult, but in terms of the fact that we didn't see each other very often, but I have to say that somehow the kids and everybody, they had like a complete understanding that I was doing something important. And for some reason, when I was coming back home, was like the biggest present. They drawing pictures and signs for me. And
did you have to be protected from them, or were you able to have any contact?
I decided not to. I was coming in from the basement. Basically, my wife was putting me in an autoclave and like a sauna. I was taking showers, clothes away, and everything. But I didn't quarantine from or separate from my family. No, I didn't. And I'm IgG negative, so.
Yeah.
So yeah, no, I probably couldn't do it in that way.
And how there's so many questions. By the way, everybody, you can write your questions in chat. I'm actually not getting that many of them, and we still have about 15 minutes or so. How's it? So what's happening now? You're sort of past the peak, I guess, of the craziness, and now what are you dealing with now?
Yeah, no, so as fast as it came, I will say, interesting enough, the numbers went down pretty quick in the last couple of weeks, thank God. And now it's all about when do we restart, how do we restart, because obviously basically the hospital is shut down completely. The ER is the ER has no admission because people are scared to come to the hospital at this point. If they don't have COVID, they don't come, and the COVID numbers are going down. So and in fact, from a medical standpoint now, it's a very interesting moment because we are trying to recall all our call back all our patient that has been discharged, and in the whole system we have discharged over 1,000 patients.
You're talking, sorry, about COVID patients now or non-COVID patients? 1,000.
No. So what's the question again?
The question is, you're saying about discharge of patients. Which patients exactly are you talking about?
No, the COVID positive patient that had COVID. We have discharged over 1,000 patients. So from the whole system. Considering also the ones that they were just seeing in the urology center and then just sent home to follow up. But we have noticed that it's probably going to be a new entity. Maybe post-COVID disease, because from one standpoint there is a component of PTSD that is amazing. I am flooded with patients with all the symptoms in the world that mostly related to the fear now to having contracted such a deadly disease, but also though even we have a number of patients that they have chronic hypoxia, so they have low oxygen saturation, and we don't know exactly why. There's claims, there is this whole idea of microemboli, sort of chronic pulmonary hypertension. That's the reason why a lot of patients, actually, we discharge all our patients on anticoagulant for 2 weeks. And so this needs to be studied. So we are trying to start, we're calling post-COVID care clinic, in which we're going to recall all of them. We're going to do some special testing, cardiopulmonary testing. It's going to be exciting because it's completely new. Nobody knows what's going on.
What about you must have had a lot. A friend of mine was a cardiologist in Italy, said that when the COVID pandemic struck, he's a cardiologist as well. All of a sudden, there are no more heart attacks. He wasn't doing any more caths. He wasn't doing anything. It's as if they all disappeared. And what happened to all the non-COVID issues, medical issues? You don't deal with cancer, but I do. But in cardio, the regular, you probably had a regular sort of a number of people. What happened? What do you expect is going to happen also?
Yeah, what happened? I don't know. It's true though. We had a drop of 80% of our acute MIs, and I don't have a good explanation. I have a lot of bad explanation, but I don't have a good one. I really don't know why that happened. It has to do for sure with probably some people, they just didn't come to the hospital and they just had an MI and they just hanging in there. The pain is going to last probably a day or two and then it's going to go away. Most of the people with an MI, especially if it's not too extensive, they just deal with it. And then, so that's probably one possibility. The other one, people are saying, I read a lot of things. I read that there is stress on the road. Now people are not driving anymore, so they don't get a heart attack. There's enough stress knowing that there's a deadly disease going around, so I'm not sure about that. Mm-hmm. Some people are saying, well, they're not going around running and they don't get heart attack running. I don't want to hear that because I'm a big runner person, so I disagree on that. So I really don't know what happened. I'm also reading a lot now about the fact that misdiagnosis, or let's say unconventional care that these people received for whatever happened to them, like an MI that was silent and or they didn't take any measure, will come back in terms of that we're going to see more heart failure, we're going to see more, we have underdiagnosed coronary artery disease is going to hit us now in the next few months. We will see. I'm not sure about that, but of course, it needs to be seen.
One of the questions, I'm looking at some of the questions are being sent in right now. What do you hope will remain of all this after the crisis is over? Very broad question, but I think a very relevant one.
It's a very broad question, and probably there's multiple aspects on this question. The one thing though that I really kept thinking about this in the latest, the role of the doctor. The role of the doctor, because I think, now I'm talking to the medical community and to the doctors in general, but also I think we push to the limit this idea that the doctor is someone that applies the guidelines and, that does the best evidence-based medicine, apply the guidelines. Whatever you have to do is already written somewhere that tells you what to do, the doctor has to be much more than that. So, I was reading this article on New England Journal of Medicine. It's a letter to the editor written by a very smart person. I'm bad with names, but you can find it. It's a letter of the editor written by the director of pulmonary at Harvard in Harvard Medical School. And he was kind of against this whole idea it was against. He was saying that unfortunately, because of the emotion of COVID, all our doctors, they had tried to find a cure, trying things. And so we kind of went against the Hippocratic oath of, first of all, do not harm. And second of all, the idea that you should try things only if there is enough clinical trial, if there is enough, which it is all true. Of course, I'm not the one saying that we should just be butchers and, let's try this, let's see what happens. No, I disagree on that. But it's also true that when you talk about the way you treat your patient, you have a little more than just what the guideline says, You have the overall picture of the patient. You know what are the goals for his life? I found in treating these patients that there is a different level of interaction between the doctor and the patient, that it's much more than just the evidence-based medicine that somehow came back in this situation. And I think if something that I hope is going to stay is exactly this. Yes.
One of the person asked to get more emotionally involved in relationship with the patients. I guess that is a result of that involvement, obviously. No.
Yeah, I am a big promoter of the emotional involvement. When I hear people saying that emotional involvement is a kind of a weakness that I can't stand, because that's the way we are. That's the way I am. I get tremendously emotionally involved with the patients. But it's also true that when you're emotionally involved, when you're emotionally involved, you don't become stupid, or you don't become dumb, but you become even smarter if you can, because then I don't know, but I would not treat badly someone that is dear to me. I'm trying to do the best that I can. So I really think that I don't know, maybe it's a superficial way of saying things, but emotional involvement, it's inevitable in this situation, and probably it's inevitable in every situation. And I don't know. I don't know there's an answer. But
well, we're coming to the end of our hour. I've got a few more questions. Maybe I'll just end it with this one. You sort of already answered this, but how are you not blocked by fear for yourself or for your family?
I mean, I don't know. I don't have a good answer to that. I had no fear whatsoever. I don't know. There is a sense when these things happens. I don't know. Maybe it's some people feel it, and I'm pretty sure some people, because I even saw in some of my colleagues, and they disappeared. But I don't know. I mean, maybe it's the sense of that you recognize that you're kind of, you're meant to be there at that moment, but you don't. When you're there, you don't. See, whatever happens, happens. But I mean, I have to be there. I mean, the first 2-3 days, I've been going around ambling patient with a surgical mask on, and I mean, people were saying, "But you don't have the right equipment." I'm like, "But he's dying. What do you want me to do?" I mean, like, you know. So you do things. That's it. Then whatever happens, happens. I don't know. I can't answer to the fear because it didn't even come to my mind. I don't know why.
Very good. Well, I'd like to thank you for this beautiful that you gave us talk and about your experience with this very, very, very difficult and unusual situation. And what really struck me is the creativity and in fact the involvement of with the patients that was asked for that was demanded, that was required in that situation, and the positivity, in fact, now and also for the future. Thank you very much, Dr. Rotatori, and thank you very much, everybody, for listening.
Thank you for having me.
Our next meeting will be June 6th at 3 p.m., not 9 p.m. The majority of you apparently preferred 3 p.m. 3 p.m. And Christina Tsinevrakis, who's a physiotherapist at St. Mary's Hospital in Montreal, will be interviewed. So thank you very much, and have a good night.
Thank you. Thanks.
Thank you, Francesco.
Bye-bye.